Today, we have a special privilege of welcoming a Singapore-based doctor to our podcast. You're the second Singapore-based doctor on our podcast, with the first one being Dr. Mina, who was the president of the Lifestyle Society of Physicians. But Dr. Soh comes from a different angle. He's a pediatrician, he's an author, and he has helped food allergy families for over a decade. Dr. Soh, welcome to Immunity Group Australia's podcast.
It's a pleasure to be here. Thank you for giving me the opportunity to share.
I'm holding in my hand your book. Now, this is only one thing that you wrote. You wrote quite a few things in life, but this book is actually a guide to everybody, not just to future doctors or current doctors, but also to lay people who would like to know about a particular approach to patient care. Could you please tell me more about your book? How did this idea come about to write a book on universal clinical reasoning?
Well, I must admit that I hadn't actually intended to write a book. To summarize it, I think the genesis of it the genesis of it began when I was really a medical student, right? So if I give you some perspective into the life of a medical student who wants to be a doctor, right? First, medical students have to study a lot. And the impression is that we've got to cram a lot of knowledge in our heads. Now, I would say that I am very different in one way from a lot of people, is that when I think that something isn't working well, I tend to go straight for it and try to find if there's some way to solve the problem rather than just suffer through it. So for example, one of the things I came up with, even as a medical student, was that I realized that, you see, when medical students have to study a lot and we have to go to the hospitals and to the clinics and we have to see many kinds of patients, there's so much to remember that when you study something, and then I often say at least 90% of it, you're going to forget within a week. And what I've just said is probably true for just about probably any medical student or any other healthcare student, not just medical students, who has to cram a lot into their heads, right? So one way that I went around this was that I realized that I could either do what everyone else does and then forget most of what I read, which is very tiresome because then you got to read it again before your exam and you got to read it again before I see patients a few years later. Or I could just say, is there some other way to study the same chapter everyone else looks at? And is there some way that you keep it in your head for years after just one reading? So you can see the benefits of that are multiple, right? Likewise, when I graduated, it became apparent because medical students don't always see everything that doctors see once they actually have to take care of patients. We live in a world where healthcare training has a lot of emphasis on knowledge, and protocols and guidelines and documents written by people who don't see the patients we see. And I think that if I put myself in the patient's shoes, I asked myself, if I was the patient, would I want my doctor to be the person who might have studied a lot, who knows the stuff in the textbooks and the guidelines, but knows when to drop that and adapt to me, the patient, my unique situation, what I say. Because we also know in healthcare that even for 10 patients, the same diagnosis, they all have different complaints and different presentations. So to me, it became clear that if I wanted to be the kind of doctor who wanted to be right as far as possible all the time for every unique patient walking through the door, then to me, the answer to that had to be a systematic technique that would automatically compel me to listen to and adapt to every unique patient walking through the door. In other words, it sounds almost like oxymoron, but it isn't. It has to be universally applicable because honestly, if you think about everything I've said, one thing that emerges is that I'm actually a very lazy person, although it's not very obvious. And to me, lazy just means that I don't like fixing mistakes, right? There is a difference between what I have to do and unnecessary work, and fixing mistakes to me is unnecessary work. So with that in mind, I simply said, look, I hate studying something and having to restudy again. To me, that's unnecessary work. That's one thing I said earlier. Likewise, I hate making mistakes, then we've got to fix the mistake. I also hate unnecessary work. I think the whole idea is that I want to help patients, I want to get it right, and that meant a universally applicable technique as simple as possible that compels me to adapt every patient walking through the door in a dynamic way. And if you look at all of the textbooks, guidelines, protocols, decision trees around the whole world, I think I can safely say that the technique I conceived and that book, which is essentially an instruction manual on how to train in the technique, is unique in that way, in that it actually starts with the patient and it ends with the patient, and it teaches its user that yes, you can study all the stuff everyone else studies, but you need to know how to prioritize the patient over your experience and the theory you think you know that is applied to anybody else. That was the basis for the technique. As for the book, if you're wondering about it,
Yes.
it got to the point where uh, I spent 3 years honing the technique and then testing it in multiple settings because to me, and I think I wrote this at the back of the book as well, I said that there is no point releasing a half-baked new technique or new invention because if people have a bad experience, right, people tend not to adopt this. So I spent another 13 odd years refining it and simplifying it to make sure that the book and the technique could be taught and understood at such a simple level that a 10-year-old child who had just gone through elementary school could literally pick up the book and read it and actually understand most, if not all of it, just by reading the book because it had been written at that level. And that's what took me so long, partly because I also got tired of repeating myself again and again and again and again and again and saying, look, it's a lot of work to write a book. But if I write a book, hopefully I don't have to repeat myself. Nina, I must say though, that unfortunately I find I still have to repeat myself, but hopefully the book makes me have to repeat myself less. Time will tell.
Every good teacher does need to remind the students over and over again, but hopefully when you have
Yes.
students who listen and apply, having a manual is always useful, having it physically in your hands. I like that you really tackle some of the big assumptions in the outside world, which even parents often make, but also physicians. Interestingly, I'm looking at a chapter on diagnosis, disease severity, and treatment, and looking at a subtitle of outgrowing. And the definition of outgrowing is it is the spontaneous improvement or resolution of the disease over time, usually taking months to years. Classic examples are said to be food allergies, chronic urticaria, asthma, and eczema. Now, as a food allergy parent, often on patient forums and Facebook groups, you hear parents talking about outgrowing, and often they ask, should I do OIT now or should I wait till my child outgrows the disease? So what would you say to these parents who have perhaps no medical background in that when they're in that thinking space? How would you approach that question?
I would start by looking at the child and assessing that individual child's likelihood of outgrowing the allergy they have. I bring this up because although there are various guides that suggest at population level, for example, this is the chance of outgrowing the allergy to food X in your population by this age. Uh, I also take the step further and say, I'm going to look at that child's personal profile and try to give that parent an individualized estimate. And why that matters is because that individualized estimate is the basis for the subsequent discussion with the parent so that they can make a fully informed decision. When the child is very unlikely to outgrow the allergy, then the argument to do OIT in a persistent allergy is much higher.
When it comes to your training, when you trained as a pediatrician and now, or even looking at historically, in the previous century, what would you say? I mean, nobody knows why we have this explosion of food allergies globally. There are lots of theories, from the whole hygiene hypothesis to the things which we use to wash ourselves and brush our teeth. What were the major shifts that you saw in your career in terms of in the allergy space? Is it growing in the Singaporean context? Do we have more food allergies today? And how should we conceptualize them as a disease today as compared to, let's say, 40, 50 years ago?
I think that's a very important question that many allergists are also grappling with, especially those interested in epidemiology. Strachan's hygiene hypothesis, and that was a very clever man who came up with the hypothesis, is mostly right with a few minor errors here and there. But to be fair, the fact that he came up with the hypothesis was an important starting point. My take on it, when I look at Singapore and when I look at patterns around the world, is that I would surmise that the jump in allergies and the far worse prognosis and the far greater prevalence of food allergies in some countries like America, Australia, I'm a bit worried about what's happening in Hong Kong as well. And even in Singapore, I think allergies are becoming more common. And I think the basis for these trends I'm talking about is actually partly based on hygiene hypothesis. In this case, however, I'll drill down specifically to number one, one of the important things that is driving the food allergies, and even in countries with far more severe and far more common food allergies, I think a lot of it comes from the diet. We know, the literature has already shown, that certain diets are quite healthy, right? In the Western countries, from our Singapore perspective, we're talking about the healthy Mediterranean diet. Now, of course, for me as a Chinese man, we talk about the healthy Asian diet, and we are very, very worried about certain methods of cooking or certain foodstuffs which tend to be far more common in the countries that tend to have the far more common, far more severe allergies. So I'm saying that this is important because we know that the method of cooking and the diversity of your diet is very important in shaping your gut microbiota, which in turn interacts with your gut immune system to actually decide the individual's chance of having a food allergy and how severe it is. And when you multiply that at a national level, that already strongly implies that we need to be very consistent, not just at the individual doctor level, but maybe even at the governmental level, about what is a healthy diet? And the question then becomes, do we even need to make certain changes at a national level or on logistics level, like the kind of foods that are really available in supermarkets? Now, I'm talking purely from an allergy prevention point of view. I am also aware that there are certain other political and lifestyle considerations that decide what is available in supermarkets, for example. But the point stands that the culture we shape, the foods we make available, the messaging given to the average person has a big impact on the diet of the family, and especially the children and the young kids who may get food allergies. And this is one of the main things. The other major factor I'll point out to that I think is modifiable other than the diet is actually the concern about the environment. The farming studies in Europe, for example, have shown that even in a very high standards of living place like Europe, in the farming communities, like there's a very low rate of allergies. And I think that has a lot to do with the environmental bacteria that the children in these communities keep running into. Or to put that another way, I'll simply say that the immune system must be perpetually kept busy. So if it is busy interacting with all the bacteria on the walls, on the floor, that the children keep encountering when they run barefoot on the grass or when they go to the animal shed, I would say the immune system seems to be interacting with all the different bacteria, and it's so busy interacting with different bacteria that this interaction keeps the immune system balanced and makes food allergies and other allergies, not just food allergies, extremely rare in the farming communities. If you translate that back into what we see first in the countries I mentioned, like Australia and America, which have a lot of severe allergies, I would say that my takeaway, which I also tell my patients, is you should not obsess so much with cleaning your walls, cleaning your floor, and it's okay to let your kids encounter some dirt. So some parents, of course, are a bit worried if I tell them, look, you know something, you don't have to mop your floor every 3 days, You don't have to go and wash the whistle every time after the sibling drops it before you hand it to their sibling to blow. Some exposure to bacteria is good. So what I'm trying to say is that also in developing countries where we know that poor sanitation does contribute to high morbidity and mortality, I'm saying that we need some hygiene. There's no doubt about it. But I'm saying that there's something called too much. And that's why I would say some bacteria is good, and we don't need to obsess so much about it, especially in urbanized settings, which is where we're seeing so much of this rise of allergies and food allergies and severe ones.
What about the animals? In the past, I guess people would live with animals more closely, whereas nowadays it's not as common to, especially domestic animals, such as the cattle or the chicken. Would that proximity to animals actually help or hinder our allergy status as humans?
I think that proximity to animals actually would help. Now, I'm also aware that we are, of course, always concerned about infectious diseases passing from animals to people. But I'm saying, aside from that, I am of the view that a lot of exposure to different kinds of bacteria is really important to keep the immune system balanced. So I'm not saying that everyone has to get a pet. I am saying, however, that nonetheless, it is perfectly okay to run barefoot on the grass, and it's perfectly okay if your floor is not super hygienic because you polish it and clean it every 2-3 days. It's okay.
I like the point that you said about the method of cooking. Now, people don't normally talk about that, the method of cooking being important. What do you mean by that? Can you maybe clarify for the audience?
There is some suggestion that when I talked about the healthy Mediterranean diet and the healthy Asian diet, a lot of that comes from the healthy methods of cooking, where we talk about things like boiling, steaming, or braising. Then on the extreme other end of things, the unhealthy methods, which happen to include deep frying and to some extent even grilling, there are concerns about that. And when I say concerns, I'm not just talking about the concerns about the carcinogenic potential of those unhealthy methods, which is already well described, but there's also some question about whether those methods may contribute even to the final form and nutrition of the food that the person then takes in, which may affect the gut microbiota. Now, I would concede that I am not aware of any systematic randomized control trial or anything that proves what I just said. But if you ask me, uh, do we need such a randomized control trial? If practically speaking, we already know about the harmful health effects of the unhealthy cooking methods to start with, especially from the point of cancer. Right? I'm not sure we need a trial just to check for the allergenic potential. I say this because I would imagine that if I was on the ethics board and if I was asked to approve a trial to compare an obviously known unhealthy method which raises the chance of cancer in participants, I'm not sure the ethics board will ever approve such a trial. You know what I mean? Yeah.
And I remember from talking to you previously in our previous discussions, you were a student in Melbourne, but there was an issue with the food in Melbourne that it was not as healthy as in Singapore. What would you say to that?
Well, I would just say that um, the time in Melbourne was highly enjoyable, and I actually did enjoy the food. I guess the issue is that because I've been so used to eating the Asian foods and the way it's been cooked that I apologize. I must say to anyone here who's listening, and if you're in Melbourne, I like the Chinatown. I like the food. It's just I just couldn't get fully used to the fact that it's just not the same as the ones but in Singapore.
Totally fair enough. There are lots of cultures, including my own Serbian culture, where there are a lot of myths prevalent about food allergies, such as, they never existed in the past. Yes, yet the mortality rate, 1 in 4 or 5 children used to die from unknown causes only, 50, 60 years ago. What happens in the Chinese culture? Are there also those prevalent myths about, well, there are no food allergies in the Chinese community globally, or how is it for a doctor with a Chinese background when you encounter those myths? How do you battle them scientifically?
Well, I would say first, there are, to my knowledge, myths in probably any culture. Some of those, I think are actually well-meaning messages passed down from generation to generation. But I think we're all also familiar with the game called telephone, where one person passes a message to person two passes a message to person three, and we all know that the game of telephone shows that when messages are passed down from one person to the next, inevitably they get warped to the point that it actually can become a myth. And therefore, when I run into myths, and in my practice, I always have to encounter and dispel some myth every day for certain when I'm running a clinic. I think the issue is that it, as humans, right, as humans, sometimes we want to believe information passed to us, especially this from an elder or from the internet. And I think as a doctor, or even not as a doctor, as someone trying to help any patient, I think it's important to teach them how to discern the truth from the myth, especially if it helps their child or if it helps the patient. That's the whole point. So how I handle it is that I actually prefer not to go head on and tell them it's a myth point blank because that's a very unpleasant thing to do. I think it's more important that I draw on what the parents themselves often describe in the history. And sometimes, by the time they've come to see me, if I have that history from them and they have have made some observations that already forewarns them that the myth is not actually true to start with, right? And I first meet them with a fundamental issue for what confronts the child, because that's actually the most important thing. Like myth or no myth, And even if patients walk in saying, I want a test, I want a treatment, I always say the universal unspoken question when one patient is, what is wrong and what can be done to help me or help my child? That is the real question that every patient wants answered. If you answer that question, you will answer every other question about, so what I'm told, is this a myth? Do I need a test? Do I need a treatment? Once I have drawn on not only my own theoretical knowledge as a doctor, and maybe test results are needed, but most important is what the patient themselves has seen for themselves and described to me. I point out that this is what they themselves know, this is what they themselves verified, and this is what they, or if it's a child, this is what the child has. And then at that point, often the parent will resurface the myth or the thing that they have been living under all this while. And then I politely point out that if the myth is mutually exclusive to what needs to be done for the child, I then explain why it is a myth and how it is as such. And then I try not to say too much more about the myth, because I think ultimately the truth speaks for itself. And most patients, if given a very clear picture of what's going on, right? I often say in medicine, it's not just our knowledge, it's not just how much we care for patients, it is the clarity that we give to patients that then gives them the confidence to believe what the doctor says and follow our advice, and also the confidence to know when to let go of the myth. So that confidence is possible if we give clarity. And that's how I handle that.
I think that's a great answer. In your book, you talk a lot about prejudice, values versus prejudice. But what came to mind when I read that particular chapter is sometimes doctors have prejudice as well. So, for example, in Australia, but in many countries worldwide, OIT is viewed in a prejudiced way by practitioners who think it's too dangerous, who think it's not worth it. And for them, it's easy to say, avoid. But for the parents, like, our own food allergy family, having crossed the other side of the bridge and having experienced food freedom, you would never want to go back to what your life was before. So, how would the parental community, for example, deal with that prejudice, which is everywhere in the food allergy world when it comes to OIT specifically?
Yes, that is a difficult question, partly because, as a healthcare professional myself, right, I would feel bad about writing so openly about things like this, but also admit that part of the reason I wrote that book is because I also admit that these are the realities of the healthcare professionals. I mean, healthcare professionals are human, and being human, they are subject to the same limitations, prejudices, and flaws that any human can have. And we also further fair to everyone else, I'll say I have my own prejudices and all. And I think it's really important that I know how to address my own prejudices, take them aside, look at them coldly and go, this prejudgment I have about something, is it based on ignorance? Is it based on my own values? Or is it based on fact? And I think being able to ask ourselves that question coldly and be able to answer that tough question honestly helps us realize when we should be prepared to drop our prejudice versus go with it. But I recall your question. So going back to your question, I think for the parents, there are maybe two ways to handle this. The first way, and maybe the easier way to handle it, is that I'm aware that many parent groups, in any part of the world, I'm sure they have social media, their parent forums, where they actually, a parent puts up a post or a question of, my kid has this problem, which doctor would you recommend, right? And if the parents, and I would often say that to parents who put up that post, it often helps if you are more specific in your question. So as I myself teach my own students, right? Specific questions or specific information help get you specific answers. So if prejudice is a concern for that parent, if they put out a single post asking for help, and then when they should critically look at the responses they get, right? What you put there actually influences your responses. You would probably want to see not just which doctors are recommended, but depending on what you ask, your respondents might have been prompted to say, okay, do you think this doctor is open to this treatment like OIT or some such or not? So that's one way, because usually, if enough patients have seen enough doctors in the area, usually the composite total of the different responses gives you some idea of who it probably may do a better job and who may not. So this is one way, because the only other way I know of is for the parent to seek out a doctor. And you seek out a doctor, again, I recommend maybe asking around, try and find which doctor is good at this. And when you go in to see the doctor, it's important that the parent themselves remains open to judging the doctor, not based on what any preconceived ideas they may have about the doctor and what the doctor does, but just go in and show the doctor honestly, this is my concern, this is what I'm dealing with, and then see the doctor's response. I say this because it's very important, I think, for patients to be able to coldly look at a doctor without any prejudice themselves and see how the doctor responds. And often teach that if a doctor is if the patient has some concerns about the doctor, it's probably a good idea to step back and maybe seek a second or third opinion and discuss that with the next doctor. For example, if I am the next doctor, I point out that I am not in any situation to judge what exactly was said and done because I wasn't at the consultation. I don't know what the patient had said to the doctor in the first place, to prompt whatever information the doctor said to them. And I bring this up because a second or third opinion, even if it's very painful to get second or third opinions, actually gives the patient a good breath of the mental attitude, the mentality and the character of the doctors that they have consulted. That's the best I can suggest.
I think that applies to pretty much every area of medicine, even like when we break our hand, often, the different surgical ways of handling that. In your book, you often talk about, in terms of diagnostics, when a doctor could be wrong or when they could be ignorant. What does ignorance in that context mean?
Well, ignorance can be in two ways. Ignorance can be from a general knowledge experience point of view. Look, if I'm the doctor, I think a doctor who is humble enough to say they don't know will openly say they don't know. I bring this up because clearly there's the other group of doctors where sometimes when, to be fair, doctors are human. Humans have egos. Sometimes the doctor doesn't want to admit that they don't know. So they end up saying something else which may not be entirely accurate. Right? So that is the general knowledge point of view. And usually when someone has that flaw, it's often easy to pick up. Just if the patient does their own search very quickly and looks at some references. The second type of ignorance actually comes from ignorance of the patient's perspective, which is part of the reason for the book. I point this out because you see, if we follow population guidelines and protocols and all, right, it's very easy to say, look, common things happen commonly. Why do I need to pay attention to everything the patient has to say to me? So although we can ask the questions, right, I think Aristotle was credited with saying this, right? Asking the right questions, half the answer. If the doctor does not ask the right questions, the doctor will not get the answers that help them become fully knowledgeable of the patient's perspective and values. Then because of that, they can be ignorant of what truly matters to the patient. And sometimes this creates friction. If the patient does not feel happy about the advice given or the treatment plan. And I think in that situation, it is important for the patient to bring up their objections or their concerns. So to give the doctor at least a chance to fix their ignorance of what the patient truly feels about all of this.
It's a very consultative, I guess, way of looking at medicine. I just keep thinking of, communist Yugoslavia and doctors I grew up with, and often there would be no discussion even allowed. So it's a very nice, in modern day times, we have that privilege of being able to voice our concerns to the doctors. In many cultures, it's probably not even allowed still.
To
The
be fair,
patient
it is
concerns.
yeah. To be fair, it is still very common. That's why in my book I also talked about the classic, what people call the classic top-down traditional. Doctor tells patient what to do. Patient's supposed to just agree and follow advice, full stop. And I don't agree with that because I think that no matter how smart the doctor is, the doctor will never know the patient's values and preferences as well as the patient. So to me, the best healthcare is only possible with a partnership mentality. To me, a wise, empathic doctor, I often say the most powerful empaths I've ever met are people who knew, and these are people in any profession, they knew that they would never know their client or their patient as well as the patient knows themselves. So those people are very good at stepping back and saying, I need to work with you, instead I need to order you what to do. And I think those are the best partnerships and they get the best results.
I love that. It goes to the consent and collaboration in healthcare, which I think is still revolutionary in many cultures worldwide. So I hope that your book is translated into other languages as well. And you also often talk about patient expectations. What if expectations are too big or unrealistic?
Then again, that is where the doctor just has to stick to the facts and the truth and talk about what is possible. Um, to be fair to the patient, those expectations can be partly fueled by what they have heard, maybe from others who may not be well informed. It may be stuff written on the internet, and you and I know on the internet there's a lot of nonsense, a lot of which is actually not true. Right? I often say that people who know what's happening often don't have a lot of time to write a lot of stuff on the internet. They're too busy actually doing the work on the ground. Uh, and therefore, I think that ultimately, as healthcare professionals, not just doctors, but I think any healthcare professional needs to go in understanding that their primary role is to figure out what the patient has and to give clarity and to be factual and to learn to listen to the patient and adapt to the patient. I think that is the most important starting point.
I love that. When it comes to doctors' mental health themselves, I mean, medical profession, like uh, a lot of professions where you deal with humans directly, has a tendency to have poor mental health amongst healthcare professionals. What would be some tips from you for either medical students or your colleagues who are struggling with mental health as doctors?
Hmm. I think mental health, uh, or health for that matter, can be discretely broken up into a few subcomponents. I bring this up because these subcomponents are actually all synergistic with each other. But why I bring them up as discrete subcomponents is because each discrete subcomponent requires dedicated attention, reflection, and changes to your habits and lifestyle to optimize it. And if you go after this systematically one at a time, you optimize everything, and all of that contributes to your overall mental health. So with that, the sub areas I was talking about include number one, uh, really your emotional health. So we talk about emotional intelligence, and emotional intelligence has further sub areas that I think I'm not going to go into in great detail. That is things like awareness, management, so on and so forth. And I think emotional health essentially requires that person to be aware of their emotions and then deliberately train in that. So, for example, I would say that the parent who wants to raise an emotionally intelligent child, because whatever good habits or bad habits the child has, they're carrying to adulthood, would do well to look at one or two of the books on emotional intelligence and sit down with the child and do what I suggest or call emotional expression exercises. Just pick one thing, ask the child to discuss or describe one emotion they had based on one event the child has spoken to the parent about that day. Of course, this implies that the parent must be talking to the child each day because parents should know what's happening to their children. And when children have these like interactions, these personal interactions with the parent role models those sessions by doing that discussion themselves, like showing the child how it's done. That is how I think emotional intelligence parents can deliberately inculcate the awareness and ability to express that in their children. And that's useful because once the child can put words to it, and once they are used to admitting themselves what it is and recognize it, then it is much easier for them to learn how to manage it constructively. For example, if you talk about anger management, the first question to me is always, yes, but does that person even recognize that they're angry and they know what to do about it constructively rather than just react on the spot? Right? So that is emotional health in a nutshell. There is also what we call mental health. And mental health, how to put it? Um, I suppose you could say that some people talk about spiritual health. So to me, some people, when they say spiritual health, they talk about religion. To me, I think whether you have a religion or not is not critical as long as you know what you're here to do. So this is not emotional health. It's more like an anchor where you're aware of your own identity, your own purpose, and what you're here to do. People who are very clear in their identity and roles often are very purposeful in what they do. And because they know what they're doing, they're not drifting aimlessly, right? They are so grounded that that identity, which may include a religion or not, makes it very easy for them to move through life, so they don't have so much conflict or stress because they know what they're here to do and they know what they are going to do in almost any situation that needs them, and that helps them a lot. The last area is actually physical health, because we all know that many of the things that we do physically would be useful. So when people talk about exercise, exercise is useful not just for physical health itself, but intense or regular exercise also releases certain chemicals like endorphins and all, and that actually helps with stress management. Right. Or having someone who is good at all three, someone who is emotionally intelligent, someone who is anchored in their identity and knows what they're here to do in any situation they're ever going to meet, and therefore it's not stressed or conflicted when they run into unpleasant situations, which always happens to any of us, and someone who is feeling physically confident, powerful, capable, and is engaging in regular exercise that makes sure that they are even better able to handle stress, is clearly someone who would be in very good mentorship. Of course, I make it sound easy. The issue is that all those three things require dedicated effort.
And when it comes to primary school children, in Australia at least, there is a mental health crisis amongst children, especially those who have gone through COVID as toddlers. And the social media is actually being banned in Australia. So as of December this year, social media will be banned for anybody under 16, including, as of yesterday, YouTube accounts. There is a lot of talk that young children have committed harm or have been harmed by exposure to violence, which they saw on social media. Now, interestingly, you actually talk about violence on screen in your book and how some of that can be replicated in human behavior. In your experience as a pediatrician in Singapore, do you see that sort of increase in decline in mental health amongst sort of primary school kids in particular? And do you think there is a link to that screen addiction, or how would you describe this whole trend globally?
I do think that in Singapore, just by what I'm seeing in clinic, and even when I'm outside clinic, I do think there is a marked rise in unhealthy behaviors linked to screen time and visibly screen addiction. And that is a huge concern. And I also agree that that adversely affects the emotional health of the children directly and indirectly. I bring this up because the first the direct ones that issues that we can see is that when a child spends a lot of time in something that gives them pleasure, like the screen or the handphone or the game or something, the issue here is that they become very unhappy when they are not allowed to have that device. That sometimes parents are very tired, they're working, they just give the child the screen time so the parents can chill. I understand that, but it is not it actually starts becoming a habit and becomes a bad habit, and then becomes very hard to break because parents often don't want to fight with their children. I think this is also a universal truth. As a result, because the effects of the screen time have been actually quite well described in people, there's multiple studies in adults and children, I would strongly advocate against screen time. Now, I will further split screen time into what I call entertainment type screen time and educational screen time. And I'll say educational screen time is a mixed bag. It depends on the form the education takes, because if the form is, to me, unhealthy, that is still unhealthy. Entertainment screen time may have some problems. I bring this up because you see, we don't exist in a vacuum, right? To a child, with 24 hours a day, there are various options for recreation or rest. And if I had to look at screen time versus all the other options, I would have said that screen time is clearly less healthy than the other options. And so that brings me to the next point. There's something called opportunity cost, right? So that is the indirect harm I'm talking about. When children, or even adults for that matter, spend a lot of time on their screens, the fact is that they're not spending time interacting with their loved ones, with the people who are supposed to be there for them, who are supposed to know them well, and are supposed to take care of them. And when you're not doing that, then you're actually losing the opportunity to bond and to learn, hopefully, from good role models in front of you because you're stuck to your screen. So to me, that is really one form of indirect harm. The other indirect harm comes from the fact that if they are playing the screen or such, as I pointed out, then they're not doing the other healthy options. I bring this up because if you look at various excellent references on this, and I believe I just recently read a stress report by I think it was American Medical Association. They pointed out that in their studies, it was quite clear that the um, high levels of stress, as far back as many years ago, especially in teenagers and older, would seem to be associated with more time spent on sedentary activities, aka screen time, versus the ones who were not so stressed and they were doing other things like exercise, for example. I think every bit of literature, every study, every report is very consistent. It all shows the same thing.
So it's us as the parents who tend to give, mobile phone to a toddler. And then once they get addicted, then we blame social media. However, our own behavior, we're often not self-reflective, I guess, in that sense. One question which I've come across a lot in the last couple of months since I've been sort of looking at the sort of baby space, babies and food allergies, if that's something you would like to tackle as well. A lot of parents are so scared when they have a first child with food allergies and then they have a baby. Um, what can they do to minimize the potential of having a second child, a third or fourth child with allergic disease? Is there anything they can do, or is it genetic?
Hmm. I think it is both genetic and environmental because the same family, arguably the same genes, also has the same environment that may predispose the children to food allergies anyway. So genetics, you and I cannot change, but environment is something we can talk about. I think previously you asked about some environmental changes related to hygiene hypothesis, and I've spoken about that. I think all that is definitely very important. The other thing that can be directly done is that we know, and for this I'll actually defer to the other illustrious peers of mine, like Professor Gideon Leck, who actually was probably instrumental in some of the studies that pushed very hard for saying, look, we need to start introducing the so-called allergenic foods as early as possible, as early as 3+ months of age in the weaning diet, because the early and consistent repeated intake of the allergenic foods is what has been shown to prevent the food allergies, especially in high-risk children. So I bring this up because to me, there are two groups of children. I don't want to stress every parent to do every of these things for their child because it depends on their child's personal profile. To me, if the child already has other siblings, or the parents have a history clearly of food allergies in childhood, that next baby is clearly at high risk of food allergies, which means this intentional intervention of start the weaning foods, start them early, start them at 3+ months of age, because that window of opportunity to intervene is probably somewhere in the around 3 to 4 months of age, up to maybe about 11 months to as late as maybe 12 months of age. So the earlier you start, the greater the chance of preventing the food allergies. I think that's really important for high-risk children. Just now I said the second group, that is the low-risk children. So when I say for low-risk children, low risk is not no risk. So I would say that even for the low-risk children, it might be worth it for the parents to start giving the allergenic foods anyway. And I bring this up because the early introduction of allergenic, so-called allergenic foods has two benefits. It is not just the prevention of allergy, it is also important in the calories and the nutrition. Because in developed countries, the issue, one of the most common issues, is actually nutritional deficiencies. And nutritional deficiencies are particularly common in infancy. And if the parents insist on, say, for example, exclusive breastfeeding alone for as long as possible, the indirect consequence of that is that that is something that could possibly increase or worsen the nutrient deficiencies because they're not taking the weaning foods as early as 3+4 months of age.
Wow, that's a great advice. I think a lot of our listeners who have babies or who are contemplating another child could benefit from your wisdom and that particular advice. Dr. Soh, thank you so much. I think we've covered a lot of topics for today. I encourage our listeners to let us know if they have more questions so we can do a follow-up interview in the future. And we look forward to your next book.
Goodness, that's a lot of work. I wrote that book partly because I hoped I wouldn't have to write another one. We will see. In any case, it's been a pleasure talking to you.